Dr. Constantinidis, maybe I can start with you. Why do we really need advanced 3D technology? For which kind of patients, for instance?
First of all, I would like to say that for me personally, for open procedures, the 3D technology is a revolution. It's a revolution because it provides me an excellent visualization with a three-dimensional and stereoscopic view, and this was an advantage only from the microscope years before. Then we have an excellent and high depth of the operative field. We have a better feeling to see what happens in the depth between the anatomical structures. We have an excellent magnification, and we have an excellent reproduction of the colors. It helps me very much in education, in documentation. I use it nearly routinely in open procedures, and also if I do my rhinoplasties. And there is also very helpful for our patients, because there is a lot work done in research that demonstrates that it makes our work shorter, and so the recovery time for the patients is shorter, and that means we have a more minimal invasive procedure. The patients, I can tell you, I have experience in open procedures. I use it now more than 1 year in endoscopic sinus surgery, and I found that if I go with my endoscope in a narrow space and there is bleeding, I have a little bit more problem, let's say, up to now with the 3D technology than with the 2D technology. And we need enough space if I use extended approaches, or if I perform a skull base surgery, then it's better. But up to now, for me personally, the advantages are more in the open procedures and in extended endoscopic sinus and skull base procedures.
Dr. Leunig, can we have your opinion as well?
Yes. I think maybe for every patient, you can use 3D imaging for every patient, but it depends what are the real benefits in the patient. So when you do, for instance, your sinus surgery, your procedure, in the narrow spaces, as just mentioned, maybe there's not really a big advantage with the 3D technology, but as soon as you come in more spaces, in wider, anatomical areas like the posterior ethmoid or even sphenoid sinus or to the anterior skull base, it may be of great benefit for the patient.
Dr. Carrie?
My experience of this is pretty limited. I've had an opportunity to use it in cadaveric dissection, and I've had an opportunity to use it to a limited extent endonasally. Clearly, there's a steep learning curve for the surgeon. And the interesting thing that I found was that actually a very inexperienced surgeon seemed to take the whole concept on more easily than I did. Maybe that's just me, but the 3D depth and being used to 2D for so long. As we were discussing earlier, the real benefits seem to be when you have a wide open space where you can view the panorama, which you don't necessarily achieve in the front of the nose or in the middle portion of the nose. When you get back to the larger sinuses, the sphenoid sinus, and it really seems to come into its own.
Dr. Bachert?
Well, I didn't have the opportunity yet to look through it, and I'm used to look with one eye. As an endoscopist, that's what you do. Some people even close the other eye. I don't do that because I don't see much on that eye anyway, so I'm looking with one eye. And let's say, I would need to be convinced what the advantages are. And I think I totally agree with, there might be indications where it's really helpful, and I think the task is to determine which operations really would be a candidate for such, great technology, but I'm doubting that we should do every routine sinus surgery with that instrumentation. It is narrow, and we all know, and we all have our sort of points where where we focus on, where we built up our anatomical model of this specific patient. So we have done surgery so far without it, and I think we could go on. The question is, and I think that needs to be defined, in which patient would it really be an advantage? And maybe there are situations where you should have it to perform the surgery.
Yes. May I have a comment? I think that we have to consider, when we have a new tool, we have to use it as much as we can.
Yes.
To feel the difference.
Sure.
Otherwise, if you keep the new tool only for advance, when you run for surgery, you are not ready to know very well. And the real difficulty in the narrow space, it's only that you need to clean much more the instrument. Because if with the monoscope, the 2D endoscope, you have a foggy signal on the border, nothing happens, you can go on. If this happens in 3D, it's like one eye. So you have to stop, and you need to clean. So you need a different training. This will be much more easy for our youngest, because the younger doctor, I think, in the future will start directly with 3D. No way, because the only thing that blocked the 3D evolution was the quality of the image.
Dr. Molteni, use it as much as possible?
I have another comment that we have to keep in mind that we are talking about a new technology and not a new surgical approach. So when we are talking about which indication is not a new operation or a new surgical approach that we have to use in this patient or in this pathology. We have a new technology, so we can use it whenever we need it. And as Professor Castelnuovo said, the more we use it, the more we become confident with it. And then after first initial training, we can choose better when to use it or when we have some advantages in using it and when not.